Thank you, Mr. Chair. In late 2021, early 2022, there was unfortunately a blastomycosis outbreak in the Constance Lake area, which is north of our service area. And it infected a First Nations community, and sadly, 5 individuals passed away during that outbreak. As a consequence of that outbreak, there was a coroner's investigation that went on to see what went wrong. And the report for that came out in December and highlighted several errors and areas of improvement that could be done at the national level, the provincial level, as well as at the local public health level for the public health unit in that region. It doesn't technically apply to us because we are not part of that region, but nonetheless, we want to be proactive and learn from the experiences of others to make sure something like that could never happen here. So hence, that is the reason for the presentation today. I will quickly flag for you that in the addendum package, there is a supplementary document that provides some additional detail around this topic. But to go into the full details of the presentation, I'm going to invite our acting Associate Medical Officer of Health, Dr. Emily Groot, to come up and present. She's a former regional coroner. She's an expert in preventing infectious diseases, and she has been one of our champions around Indigenous reconciliation internally. And there's probably no better person to speak to this topic than her.
Thank you, Dr. Hergy. Welcome.
Thanks for that introduction. And for those of you who I haven't met before, I'm Dr. Emily Groot. I'm the acting Associate Medical Officer. By way of background, I grew up in Sault Ste. Marie on the territory of Garden River and Batchewana First Nations, and I first moved to Sudbury in 2019 to work as a regional supervising coroner with the Office of the Chief Coroner, so I have a bit of familiarity with the inquest process. Also, as part of that work, I worked very closely with an agency called the Family Information Liaison Unit at the Ministry of the Attorney General. And that agency's role is to bring information to the families of missing and murdered Indigenous women and girls. So as a regional supervising coroner, I met with many families of Indigenous people whose loved ones have passed away. And I wanted to share that by way of background because as part of that work, I wore a ribbon skirt during some of the ceremonies as a way to honor people who had passed. And so that's also where I'm wearing this skirt today. It's also the reason that I wanted to use the full name of the inquest title, both in your agenda package and to start our discussion today, because I wanted to be very explicit in honoring the lives of people who've lost. And so I'd actually, if I can get my slides to work, I just wanted to start with a moment of silence for the 5 individuals who passed away as a result of this infection.
Just make sure he's speaking to the microphone. So I'm not sure if people online and they hear us.
I hope it might be picked up by the ceiling. Yeah.
Okay, so they can hear us fine online.
But please, I think if you can flag virtually, but I can't see.
Is everyone online? Is everything okay with the audio?
Yep.
Okay, thanks, Brian.
Thank you. I'll provide a little bit of background on blastomycosis first, just to give a little bit of context to the outbreak. Blastomycosis is a lung infection that's caused by the Blastomyces fungus. And this is a fungus that's endemic in the soil in northern Ontario, especially northwestern Ontario and in the region that we serve, Manitoba Island. And this fungus prefers damp, acidic soil near waterways. So of course, this region, lots of waterways, lots of acidic soil goes from coniferous trees and also industrial activity. And anybody involved in outdoor activities can be exposed dust dries, you breathe it in, it happens to be contaminated with spores of this fungus and it ends up in your lungs. People can also be exposed even indoors. Dust, of course, goes into our homes. Sometimes, but very rarely, outbreaks can be linked to a specific event that disturbs the soil, for example, construction or demolition, but typically it's not possible to identify a source. Even if we tested soil, we might find the fungus and we don't know if it's connected to someone's illness. In Ontario, we see sort of 50 to 130 cases per year of this infection. So it's not very common, which is a factor in this outbreak because when things aren't common, they're harder to pick up. And then in our region specifically, we saw 3 cases last year and 5 cases the year before that. So even though it's endemic in our region, this fungus lives in the soil, we still don't see that many cases. The infection itself takes a long time to develop. So anywhere between 1 to 6 months. And you might ask, if anybody who can breathe in this soil might be infected and this fungus lives in the soil that's around us, why is this relatively rare? It's because even though it grows in the soil, it's distributed unequally and it's relatively rare even in the soil. When someone breathes in the spores, often their immune systems are strong enough just to fight off the fungus without any additional intervention. And even if our immune systems don't fight off the fungus can sometimes just die. It wants to live in the soil, doesn't prefer to live in people's lungs. And then I think another factor in terms of public health management is that this isn't an infection that can spread from person to person or animal to person. So for example, if I was sick with blastomycosis, even if I was up here in this room with all of you, I could transmit it onwards. It needs to be inhaled. And so, like I said, lung infection is the most common presentation. Usually presents as a form of pneumonia. But it can range all the way from almost no symptoms at all. You feel a little bit fatigued, you think you have the flu, up to life-threatening and severe infection with requiring admission to the intensive care unit. And often that means, though, that lots of people who are infected don't even seek care. Their immune systems fight this off, and we don't even know about it. So the people who do get quite sick with this disease, they usually have, cough, chest heaviness, difficulty breathing. But of course, common things being common, this is something that's often misdiagnosed as a bacterial infection first. Fungal infections are quite rare. And, as doctors, we're trained, at least in our region, the saying is when you hear hoofbeats, think horses, not zebras. So you've got to think of common things first, and then you think of rare things. And that was a factor in identifying this outbreak, that it's easiest from a heuristic perspective to go to the things that are common first and not think of things that are uncommon. It is treatable with antifungal medication. Of course, that means there's complications because typically if you think that someone has pneumonia, you'll treat them with antibiotics, which treat bacterial infections, not antifungals, which treat fungal infections. The role of health units in this disease is threefold. The first is surveillance. One of our jobs is to identify these infections and understand where they're occurring, and also whether or not they're individual cases or part of a larger outbreak. Because of the challenges that I've mentioned in diagnosing this infection, our role also includes healthcare provider education. Not so much relevant to this outbreak, but in previous outbreaks, one of the challenges even been, for example, locum physicians who come to Northern Ontario who wouldn't have seen blastomycosis in their region, aren't as familiar with it. If you start to move towards Northwestern Ontario, it's something that people who work there regularly see. And so that is a role of health units, is providing them healthcare provider education. There's also a role for public education to say that these are the types of symptoms that you should seek care for. And so in this particular outbreak, there was an inquest And an inquest is a public hearing. In this case, it was conducted by a coroner. Technically, the Coroner's Act permits lawyers or retired judges to also perform inquests, but they're almost always presided over by a coroner. Most importantly, is that the information that's heard at the inquest is heard by, if they're open to the public, but they're heard by 5 jury members. And the jury members are tasked with making conclusions about the facts of the death. So who the deceased are, where they died, how they died. But they also may make recommendations to prevent similar deaths in the future. And so that's where the role of the inquest overlaps very closely with the role of public health agencies, in that we're all ultimately looking to eliminate preventable death. And so in this situation, there was a blastomycosis outbreak affecting Constance Lake First Nation. So this is north of the service area that Public Health Submarine District serves. 40 people in Constance Lake First Nation were affected, and the 5 people we've already identified unfortunately died as a result of this. And so there was a recently concluded inquest where the public and members of the jury deliberated and asked questions about the circumstances of these deaths. And a lot of the challenges that arose were challenges of communication, collaboration, timeliness of information sharing that impacted the community and their ability to access care. And the jury ultimately made 79 recommendations to prevent similar deaths in the future, and of which we've extracted those that were specific to the local public health agency. Although, as Dr. Hergy indicated, they're not directed at public health submarine districts, but I think it provides us an opportunity to say, these are recommendations that were directed at another local public health agency. What can we learn from them? And I want to pay special thanks to the Indigenous Public Health team and to the Environmental Health team for supporting me in providing this information to you. And so the Indigenous Public Health team helped to prepare the package that goes in depth on each of these recommendations related to the local public health agencies, and then summarized what public health submarine districts is already doing or will be doing that help to address these recommendations. So we'll go through the 9 that are relevant to the public health agencies. The first recommendation focuses on Joyce's principle. For those of you who aren't familiar with Joyce's principle, it also unfortunately stems from the death of a First Nations woman, Joyce Eschekorn, who passed away the year prior to this outbreak in a hospital in Quebec, where systemic racism and discrimination were ultimately the cause of her death. And so the principle is that that Indigenous peoples should have equitable and equal access to health and social services. And so recommendation 1 reflects Joyce's principle, and some of the work that we're doing to try to work to align our agency with this principle include things like advancing the Positive Spaces Initiative, and that includes a focus on two-spirited individuals in our communities. Of course, as board members know, as you are working through the Unlearning and Intervening project, some of the staff of our agency are also working through that project, and we have existing mandatory cultural safety and anti-racism training. Recommendation 4 reiterates the importance of 2 of the calls to action from the Truth and Reconciliation Commission. Call to Action 22, which focuses on the importance of Indigenous healing practices and recognizing the importance of Indigenous healing practices. This is something that, as an agency, we are committed to working towards. We've provided ourselves with a deadline of 2027 to look to specifically the direct client services that we provide and ways in which we might be able to more explicitly incorporate Indigenous living practices and culturally safe care in the direct service delivery of client care. Call to action 23 focuses on Indigenous health workforce and cultural safety, meaning reflection of Indigenous people in the workforce of our agency. Some of the work we're already doing there includes things like promoting employment opportunities to Indigenous job boards and networks. And then I just want to note in particular the Indigenous public health team that helped to prepare this for you to review today are all Anishinaabe. And of course, Angela, we have a dedicated Indigenous board member, so thank you for that support. The second piece of that, though, is to say it's not just Indigenous people who need to be represented, but the space in which they work also has to be safe. And so part of the work we're continuing to do is around that anti-racism education within our organization. Recommendations 24, 27, and 28 focus on the interagency communication, collaboration, and emergency preparedness within public health. And one of the terms I've heard used to describe the way in which sometimes public health service delivery is delivered to First Nations communities is jurisdictional neglect. There are a lot of people and a lot of agencies who are involved, but that always means that there's someone else to point to and say this is someone else's job. And so I think it's important for our agency, and we continue to do this work, is to sit down with our provincial and federal partners and to say, whose work is this? And most importantly, is that First Nations communities are leading or part of those conversations, because this is ultimately, a community sovereignty, and they're most important in deciding how those services or which services are delivered. So I included in your more wholesome package in the agenda, it lists some of the services we're delivering in First Nations communities by program standard. But I think one of the, I think that these recommendations reinforce the work that we're doing in terms of ongoing conversation with First Nations communities, Public Health Ontario, the Ministry of Health, and Indigenous Services Canada to really identify how to best and when to best deliver services. Recommendation 31 echoes some of the sentiments of previous recommendations with a focus on Indigenous representation on boards and at all leadership levels within the organization. And that is something that we've done as an organization to date, and will continue to work on, for example, through some of the recruitment and retention initiatives I already described, so that communities are reflected at our agency. And I think that that would also engender trust as well. And then recommendations 33, 34, and 35 focus on data. As I mentioned, there are a lot of organizations that have some role in service delivery to First Nations communities. But how those agencies collect, how or if those agencies collect or share information is not always clear. And it's not always clear how the Indigenous or First Nations community has been engaged so that they can exert sovereignty over the data that are theirs. And so I think this is the piece that I really want to highlight is the forward-looking work on Indigenous data sovereignty that our agency is undertaking to identify how or if we can collect Indigenous data in a culturally safe way that supports the delivery and sovereignty of First Nation of services, but also the sovereignty of First Nation service or of First Nations communities in the delivery of those services. And part of that centers around OCAP training. So the idea that First Nations communities should have ownership over their own data, control over their own data, ongoing access to that data, and then physical possession of that data. So that is a very high level overview of the recommendations that came from this inquest. Unfortunately, these circumstances are incredibly tragic, and I hope that we can take these recommendations and learn from them. And I think they do support a lot of the work that the agency is already doing. I'm happy to take questions.
Thank you, Dr. Zook. Questions, Bob?
Thanks very much, Dr. Groot. That was excellent. I have one comment and two questions. So as you know from your past experience being a coroner's jury recommendations are not binding, right? So that could be, I think, a challenge in getting some of these implemented. The other question I had is who else besides public health agencies were some of the, I think you said there were over 70 recommendations. So who else would have some of the recommendations been directed at? Some of the, who were some of the other groups?
Yes, I should have mentioned that. That was how I first met Bob, was that we had worked together when I was the region supervisor partner. Yeah, so to reiterate what Bob said, that coroner's jury recommendations are not binding. The Office of the Chief Coroner tracks responses, which are often made public, but other than continuing to reiterate the importance of their recommendations, they're not binding. And perhaps reflecting on my experience with inquests is one of the reasons I felt like it was important for us as an agency to review these, because otherwise, I mean, this work to make all of this public is quite significant, and I think provides a really important learning opportunity. But they're not binding. With respect to other agencies that were other than public health agencies, the hospital. Orange, the air ambulance service, was another recipient of recommendations. I think Public Health Ontario, the Ministry of Health, Indigenous Services Canada. I think those were the big players.
Okay.
Yeah.
Makes sense. And one last question, just to give some context, I had privilege to work with, collaborate with Dr. Groot several years ago, and a request came from the mining sector to look at, I think there were 10 or 15 years of coroner's information from inquests. And the industry felt that, you know, we weren't really utilizing that to the extent that we could. So what we did, as you recall, is we did an aggregate analysis of 10 or 15 years of coroner's information on mining sector fatalities. I'm just wondering are there enough incidents, you know, of this type where something like that would be considered by the coroner's office to do it, because I think it was very insightful. I think you'll agree that we've got a lot of useful information from that. So I'm just wondering if there's been any consideration to do that kind of analysis moving forward.
Yeah. The Office of the Chief Coroner, but the new Death Analyst for Safety and Health unit, I think has some capacity, so that's something that we can take back and then share back with you.
Thanks. Thank you very much.
Thank you, Bob, for the questions. Mike, you have a question?
2 questions for you, Mr. Thank you, Dr. Booth, for the presentation. Very informative. First question, in the Constance Lake incident, we noted that 5 out of 42.5% of those who were infected succumbed, likely because they were properly treated. Earlier in the presentation, you shared that in Ontario, there are usually between 50 and 130 cases annually. Do you happen to know what the rate of mortality is for those cases? And if this is aligned with what we would see within the regular 50 to 130, or if this is kind of a much higher rate of death than what we would normally see?
I wish I could get that number for you off the top of my head, but I don't have it. Let me to
That would be-
the case fatality rate. It will be easy for us to access, but I don't. Thank you.
The second question, again, I'm from rural northern Ontario, so I understand some of the challenges that are ongoing with changing physicians. So someone is in there from London for a week and someone's coming in from Windsor the following day. Is the knowledge transfer going to be targeted to the constant healthcare, like the nursing staff versus the locums who are there for an indefinite time and may not return?
Thank you. I'm also supporting clinician communication and engagement at public health center districts, and I would say that that is a real challenge for us is accessing both agency nurses and local physicians who might not be spending a considerable amount of time in the communities. Even reaching clinicians generally can be tough. There's not sort of a single place you can access everybody at once. But that's a group that's particularly tough. We do share information in places like our website that would be accessible to anybody, but you tend to know to look for it. We do send out email alerts, but then you have to know to sign up for them, for example. So they are a tough group to access. And we're working towards offering continuing medical education events for clinicians in our region as well. But again, if you're only here for a weekend, you might not access an event that's regionally specific.
Thanks, Mike. Angela, I see you have your hand up. If you have a question, please go ahead.
Yeah, Ani Bojo, Wawash Kushquedition Kos, Makododam, Chumigwech for the presentation. There are several points that I'd like to make. And I think it's imperative that the Board of Public Health hears what the true reality and some of the essence of the situations that happen within First Nations right across what you now call Canada. Clean water is a huge priority within our First Nation communities. And this is something that is the public health's jurisdiction. And not only that, but the federal government to do their due diligence. We can talk about reconciliation all we want. I have yet to see action put towards this. So the other piece that I want to make reference to, and thank you so much for the presentation. And I also want to acknowledge the Anishinaabe team that works within Sudbury Public Health under Kathy Dokise's leadership, along with Sarah Rice, who I believe is in the room there today. I think I got a glimpse of her. And so I'm certain that they were critical in developing these recommendations that have been presented to us today as a board. One of the most pressing issues is the continuation of systemic racism when it comes to the original people in our territories and their access to quality healthcare. I am very familiar with Constance Lake. As you know, I'm the Nigonsit of the Shkokmakwe Health Center, and I'm also the Nigonsit of the Sweetgrass Health Center in Cochrane. So I'm very aware of our territories, and I'm very, very aware of the lack of services that our people have access to. And with us being an interdisciplinary health center within Cochrane, we're the first to actually provide primary care in that territory. And as you know, the geography in Northern Ontario and Ontario as a whole is extremely vast. And when we're making decisions, whether it's at the federal government or provincial government, to ensure that we have access to resources to make certain that we can continue providing quality services, that's one element. But the fact of the matter is the system is extremely racist, and that's just a fact. So these 5 deaths with regards to environmental impacts, it's not just the federal government, but it is the mining industry that needs to be held accountable. And as you know, there's been certain bills that I've called out in our last board meeting and board discussion that we need to take actions to ensure that we do not continue to disrupt our land resources that is causing illnesses, and looking for environmental strategies and solutions to make sure that people have quality care and quality of clean water. So I'm very impressed with the recommendations, but my question to the board as a whole, that's fine that we have these recommendations. I need to ensure as a strategy with the Sudbury Public Board of Directors that we're putting resources to this. And I'm not going to get into the financial piece, but this is a priority. We can talk about recommendations all we want, but if you don't have a strategy for implementation, and if you don't have the proper resources to ensure implementation and action is being taken care of, then it's not going to work. So we can continue talking about this all we want, and our people are going to continue to die. Now, I will give you another example, and we provided quality care. We had to refer an external referral to 2 Indigenous, Mindaugas individuals in the Cochrane Constance Lake area, and had them referred to local hospitals, and I'm not going to mention what they are, and were turned away, and those people died with this exact same disease that very day. So this is some of them that you're bringing forward with the coroner. There's far more that people are left unseen and go unnoticed, because mainstream society still thinks that we're less human than everybody else. As beneficiaries, you all have benefited from our land, from our resources. And if we're going to move forward around what strategy looks like, if you're serious about these calls to action and what reconciliation looks like, then we need to ensure that we have the resources to that. I know that the director of Anishinaabe Affairs within public health is not even a full-time position. So we need to think about that. So that's all I have to say. Miigwech.
Thank you, Angela. I'm not sure if there's Liturgy or Dr. Crew, if you want to comment and provide any.
I can make a couple of comments, Mr. Chair. So first off, Mr. Chair, I want to thank the board member for those comments. And I think this speaks to exactly why we thought it was important to have an Indigenous person on our Board of Health, so that we can make sure that voice is given to these issues. And that's something that we always keep in mind. I do want to quickly bring attention again to the addendum that we do have in the agenda package for today, where there's a supplementary document that goes into some detail around what we are doing locally to action all of those different recommendations that are highlighted in some of the calls to action from the Truth and Reconciliation Commission. Obviously, we're doing lots of work. There's far more work to be done, and we don't shy away from that fact, and that is something we need to continue to do. In terms of funding in the budget, I'll just quickly mention that when the Director of Indigenous Public Health role was initially advertised, it was advertised as a full-time position. And the person who chose to take the job, Kathy Dokes, chose to only work part-time. So that is part of the reason why it is part-time, is a choice of the individual who we were able to hire. I think we have had the board put some real money behind Indigenous public health, so that we now have the director position, we have a manager position, and as of the most recent budget, where we added a second frontline position, we have 2 frontline positions dedicated just to Indigenous public health, and that's on top of hiring other Indigenous persons to other roles. I think that is a significant investment of resources. Obviously, there's far more work to be done. It's something we'd obviously like to continue to grow if it is possible.
Thank you, Dr. Hergy, for that. And Angela, thank you for the question, and thank you for bringing your comments forward. Is there any other questions for Dr. Guru? Just have one, not just specifically with the individuals that did pass away from the disease. Is there any, besides the drinking water, is there any other preventive, like was there any other underlying conditions that allowed for this to happen that you can speak to?
I think major developing issues, I think first, access to healthcare, access to culturally safe healthcare, and then access to culturally safe healthcare in which people would recognize and be able to diagnose osteomycosis. Some of the people who are affected by this outbreak went for quite some time before their infection was properly diagnosed and treatment was initiated. The second line medication for osteomycosis is difficult to access in Canada, so that's another underlying systemic issue. It took a long time to stand up a response to communicate information between different parties, in part because of that sort of jurisdictional neglect, where everybody can point to someone else and say this is someone else's job. And So all of that confluence of factors contributing to how large this outbreak was and how long it took to address and provide appropriate care for the people.
Thank you for that. Again, I'll ask if there's any other questions, comments. Hearing and seeing none. Thank you, Dr. Cruz.